Hello, my name is Hunter Smith, and this is Case Connections for video. I chose case 1 and case number 3 for the two cases that I would be looking at today. Case 1 starts with a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? Please discuss your rationale for this choice. The four choices are blood glucose, urinary acid, serum fat, fatty acids, and plasma glutamine. A full blood workup was ordered for this female, and the data is presented below. The initial blood ammonia level was elevated at 314 and rapidly rose to 600. The normal range for that is 17 to 80, and the urine orotic acid level was markedly elevated at 473, and the normal level is 0 to 3. And also the plasma citrulline level was normal at 10, and the normal level is between 12 and 55. So it's a little low, but not too bad. And this patient, where orotic acid levels are elevated, lists one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. Be sure to justify my answer. So my answers are as follows. Defects in the urea cycle are typically a result of deficiencies in the enzymes that are required for the breakdown of protein. Nitrogen can accumulate as ammonia, which results in elevated blood ammonia levels. And ammonia is highly toxic to the body and can cause long-term tissue damage. Arginine levels in the plasma are typically higher in these patients than normal, and glutamine levels may also rise a lot depending on the severity of the case. Increased orotic acid levels in the urine are most likely resulted from a deficiency in the enzyme ornithine transcarbamylase. In this case, the production of excess carbamyl phosphate is then converted to orotic acid. In healthy individuals, ornithine transcarbamylase will catalyze the transfer of a carbamyl group to ornithine. This reaction results in the formation of citrulline and orthophosphate. The enzyme that is least likely deficient would be the carbamyl phosphate synthetase 1. This enzyme is used to synthesize carbamyl phosphate, and the carbamyl phosphate is then used by ornithine transcarbamylase, which is thought to be deficient in this case. There's clearly the continuous production of carbamyl phosphate that is being converted to orotic acid. And if this enzyme were deficient, we would not see elevated levels of orotic acid. Beta oxidation of fatty acid defects usually involve a defect in any enzyme involved in beta oxidation or defects in the transportation of the fatty acids. These patients typically present as hypoglycemic ketosis during decreased carbohydrate intake. And it has been studied that neonates with beta oxidation defects typically present with transient hypoglycemia and elevated ammonia levels in the body. But with all of this information in mind, the best diagnostic way, in my opinion, to differentiate between these two disorders is a plasma glutamine level. Plasma glutamine levels would be elevated in a urea cycle deficiency and most likely normal if the patient had a beta oxidation deficiency. So that's the end of case 1, and I'll be moving on to case number 3 now. And case number 3 is as follows. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there is no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn, and urinalysis is performed. The results from the individual are listed below. So his plasma urate levels was 10.5, and it should be less than 7. and his urinary uric acid level was 215, and it should be around 413 plus or minus 78. So the question is, what is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. After further discussion with the patient, he tells you that he recently switched it from diet soda to regular soda because he read that fake sugar in diet soda was bad for him. He tells you that he drinks between 4 and 5 liters of soda a day. What is the potential impact of this dietary modification on the presentation of gout? So, my answer to this case is as follows here. If the patient were not consuming so much fructose, a decrease in the urinary excretion of uric acid would most likely be the answer. The urinary uric acid levels are lower than what is normally suggested, and that either signifies a decrease in urinary excretion or the body is not creating enough uric acid at all. In this case, we see that while urinary levels are low, plasma levels are high, suggesting that the body is synthesizing enough uric acid, but not enough is being excreted in the urine. This diet modification has had significant effects in the presentation of gout. Most soda that is not diet soda contains fructose or high fructose corn syrup as a primary ingredient, and high levels of fructose intake leads to increased fructose phosphorylation by fructokinase. Fructose 1-phosphate is produced. The detachments of large amounts of this phosphate can result in the diminished ATP production. And with diminished ATP, there is a decreased inhibition of purine, and excess purine is then produced. Purine will eventually break down to uric acid, and therefore the increase in purine synthesis will result in large amounts of uric acid production. And this uric acid usually goes down to the toes. I've seen this many times at my job at the hospital. I work in the emergency department, and we have plenty of patients that come in with pretty severe cases of gout. Pretty nasty looking stuff. With all this information in mind, though, the most likely reason as to why this man presented with gout is the low excretion of uric acid in the urine. The overproduction of purine causing excess uric acid does not help his cause, but there's not nearly enough uric acid that's being excreted in the urine. If this patient was excreting uric acid at a normal rate, then the overproduction of purine would be the explanation, but that is not the case here. So, final answer, not enough uric acid excretion through the urine. Thank you very much for your time, and I hope you have a good day.